Okay, good afternoon, everyone. I think it's time for us to start the proceedings for the day. And a very warm welcome to each one of you to have joined in and to participate in this important initiative being driven by our very own Dr. Shanta Kumari, the president of MOPSI, as well as the treasurer for FIGO. This entire program is being done jointly and under the ownership and leadership of FOXI to begin with, and WHO and Government of India, Ministry of Health and Family Welfare. Just to give you a bit of background, that unsafe abortions are something which are the third leading cause in our country for MMR, and therefore it needs to be addressed in a more concerted and an organized way, which is what we are trying to attempt over here. In addition to that, the laws and rules of MTP have been amended as of 2021. That is in March and September. And therefore, there is a need for all of us to get oriented to this particular changes and the amendments which are related to the MTP Act in the country. In addition to this, the important thing for us to note is that we are trying to reach all Foxians through this change which has been brought about, and we are hopeful that each one of you will carry this message forward, and your colleagues from your respective societies will be in a position to get oriented and spread the message further. On that note, today's program will be for about 2 hours. And in these 2 hours, we will be covering the first topic is MTP Amendments 2021. The second topic is going to be abortion care and the technology and the various medications and equipments which are available for us to use. I'm sure each one of our already doing it. It's just a reiteration of what we want to do and how we want to move forward with that. The next presentation is going to be on the SAVOR module, which is related to safe abortion, respect and care for the woman who is coming for the abortion, irrespective of where she's coming from, what she's doing, and how she's doing it, so long as she is coming to us for the services. And the last bit is related to the post-abortion counseling, pre-abortion counseling, as well as the availability of options related to contraception. We have 3 master trainers who are present here, who will be walking us through and conducting this whole program for us. And and the 3 of them are, we have Uma is here, Atima is here, and Surya Kumara here, who are your colleagues and who will be walking us through these presentations as we move forward. Can I request Uma to please initiate the first topic, which is related to MTP amendments. Thank you very much. And as Uma is going to walk us through this, may I request each and every colleague, if you have some questions and if you have some doubts or something that you would like to know of, please put it in the chat box. We will be answering those questions to the best of our ability towards the end of the session. So we will have an opportunity to answer those and also to interact with each one of you at the end of the session. Thank you very much. Over to you, Uma. Uma, we can't hear you. Uma, we are unable to hear you.
Pregnancy, and the rules will also tell us about the functions and the powers of
Are everybody able to hear her? Because I'm not able to hear her.
No, sir, we cannot hear. No, sir.
She's unable to mute. Why? Uma, we are still not able to hear you. Unfortunately, I don't know. You're showing as mute. Backend, please, can you help them? Help her?
Sir, there is a problem with the laptop, sir.
Okay.
Can you connect any earphones?
Uma, are you able to sort it? What is happening? Talk to us. Send us a message.
that person is 1 RM.
Ma'am, we cannot hear you.
Gosh, this is not good, Uma. Uma, we can hear you banging the keys. Please bear with us with this technical thing which Uma is probably facing. Yeah, we can hear you now.
See, the moment I start sharing, it's unmuting itself. I don't know what's the problem.
Okay, no problem. Backend, can you please play the slides for her? So, Uma, what you can do is backend will try to play the slides for you. You can walk us and go through the presentation and keep saying next.
Ma'am, now you can try, ma'am, because at that time I only did that one.
Try. Uma, try open the slide.
Okay, I'm sharing it. Just look once again.
Again, she's muted. Yeah, speak up, Uma.
Yeah, I can hear. As long as I'm not sharing, it's unmuted. If I'm trying
Okay,
to share,
no problem. Backend, can you start it because you have lost valuable time? The first presentation, do you have it?
No, sir.
Where is Sriman? Is it the other one?
Yes, in the other link.
Ask him to come here. Is he next to you? Where is he? Yeah, Oma, you can start now.
Yeah.
Yeah.
Okay, can you hear me now?
Yeah, I can hear you.
Yeah. Good afternoon and greetings from Vijayawada. Well, while we are getting connected together towards working for safer abortion for all our women, we are also have to go through the certain rules and regulations that are formulated by the government. And all this training program is to just formally inform all the obstetricians or medical practitioners to be aware of our new medical termination of pregnancy amendment act. And this program is a joint venture by FOXI and WHO to improve towards respectful abortion care. Now, getting straight into the module, in the next 15 to 20 minutes, I would be discussing about the MTP Amendment Act, which has been around for a few months in some form or the other. Now, this is to just give a formal information about the Act. What are the changes that have been made in comparison to the old rules? And what are the implications with each such change, and what way are we going to improve our practice? So let us keep it very simple. So first we should look into what are the changes and what are the changes in the rules with the new amendment law, and was it needed? Why was it? Can you move on the slides? And was the change needed at all? Yes, the change was needed because unsafe abortion is the third leading cause of maternal morbidity and mortality in our country. 8% of maternal deaths per year are due to abortions, and nearly two out of these three abortions are performed and are deemed unsafe. Nearly half of the pregnancy-related deaths are in young women who are less than 24 years. So probably because of unsafe practices or lesser availability of abortion facilities, most of the abortions were happening or deemed to be unsafe. So to improve on this, there was a need to change the MTP Act. When is abortion considered safe? Abortion carried out by appropriate methods and by trained personnel is considered safe. When we talk about safety, it should be within the gestational age limit permitted by law, by a trained person, by trained in an approved place, and by a trained person. All these things should be appropriate to enhance safety of abortion. Now, next one. This is the next slide. This is the new MTP Amendment 2021 Act, which was there, has been in the mandate by law in March 2021, and the rules have been framed at Decent Gazette on 25th of September 2021. So, what are the salient features of this new amendment law or act? So, what are the modifications in comparison to the earlier? What are the new changes? And what are the implications of what we are going to look into? Earlier, we know that there was a requirement of opinion of one provider for medical termination of pregnancy up to 12 weeks, and requirement of opinion of two medical providers or registered medical practitioners for MTP for 12 to 20 weeks, and 20 weeks was the upper limit for termination of pregnancy legally. Now, this 2021 Amendment Act brings, excuse me, the previous slide. Yeah, in this 2021 Amendment Act, there is one registered medical practitioner opinion is enough for termination of pregnancy up to 20 weeks of gestation, and two medical practitioners opinion is required for termination of pregnancy from 20 to 24 weeks of gestation. Now, what are the implications? What is the benefit of this? Increasing the gestational age limit to 24 weeks increases, and also the change in the registered medical practitioner definition increases the number of facilities, especially in public sector like public health PHCs or which are eligible for service provision till 20 weeks. Next. The next modification or the next change is is the modification for the vulnerable group of women. In the previous act, MTP is permissible beyond 20 weeks of gestation only when it is immediately necessary to save the life of pregnant women. Now, with 2021 amendment, enhanced the upper limit for 20 to 24 weeks for special and vulnerable categories of women. So now the upper limit is 24 for special and vulnerable categories of women. And also there is further enhancement for birth defects which are not compatible or which are not which are lethal on decision of medical board. So there is no upper limit when there is a birth defect which is not compatible with life or deemed lethal. What is the potential outcome of this change? It increases access for vulnerable women, and vulnerable women definition is also provided in the rules of MTP. It increases access for vulnerable women to safe and legal abortion services defined by rules committee, including violence victims, minors, among others. Next. The other modification, next. The third modification is in women who are pregnant with fetuses with birth defects and congenital anomalies. Now, as a fetal medicine specialist, I feel this is more important because the previous act, there was a provision for termination of pregnancies only up to 20 weeks of gestation. Now, with the 2021 Amendment Act, there is no upper limit. Upper limit does not apply in cases of pregnancies where there is substantial fetal abnormality or which is diagnosed and approved by the medical board as may be prescribed under the rules made under this act. Now, what constitutes the medical board? What are the procedures to be followed? I'll come up with that. But there is no upper limit. But after 24 weeks, you need to go through medical board. What is the potential outcome or what are the implications? With increasing ultrasound usage, most of the abnormalities, a few of the abnormalities like cardiac abnormalities or lethal skeletal dysplasias, which are presenting late after 20 weeks, are diagnosed, and there's no point when we are, not helping the patient and only diagnosing. So, such change will increase access to safe and legal abortion services, who often seek services late beyond legal limit for termination of pregnancies, wherever there is substantial fetal abnormality. So this change reduces unsafe abortions and court cases because after 20 weeks, most of the termination approvals were through court. So whoever have gone through will obviously notice that there was a lot of hangama going through the court cases. So now with this number of court cases will definitely come down. Next. The fourth modification is modification related to the marital status. In the previous act, the condition of failure of contraception was applicable for only married women or her husband. Now, with the present change in the act, the condition of failure of contraception can be extended for any woman or her partner. Now, with the changing socio-cultural scenario, the marital status has been changed to having a partner. So what is the potential outcome? It increases access of safe and legal abortion for women irrespective of the marriage, especially with upcoming changes in the legal age of marriage, an important advancement for increasing access to safe abortion for unmarried women. Next. This is the most important crucial modification in the Amendment Act. It discusses about the privacy. The previous slide, please. It discusses about the strengthening of the privacy. This is a new clause, and this has the previous act. In the previous act, the MTP Regulation 2023 mentioned that information should not be disclosed except under authority of law. So we were, we now have to have this in the back of our mind, that the name and other particulars of the woman, whoever seeks MTP, should not be revealed except to a person authorized by any law for the time being in force. Now, what is the benefit of that? It increases the privacy and confidentiality of abortion seekers. they might not be, most of the women are stigmatized about, seeking abortion or fears of neighbors getting to know or whatever. So you have to ensure privacy and confidentiality of abortion seekers. You shouldn't mention name and any other particulars about the patient in the payer files. And you shouldn't reveal information to any person, even her husband, by except authorized by law. So this is likely to increase safe abortion practices, safeguard women's rights and dignity of women, and provide respectable bias-free services, including counseling and further contraceptive advisors. Now, for minors, signature of guardian in the previous slide. For minors, the consent of the guardian is simplified. Now, the guardian need not necessarily be the parents. It can be anyone who is 18 years and willing to take care of the minor who is seeking MTP. This form is simplified. The next one. So come the next slide. So what are the salient features of Mtp Amendment Act? Is most important is to prioritize confidentiality and safety. Again, the name repeating the same thing. Name and other particulars of any woman seeking abortion should be confidential and has to be revealed only to an authorized person by law for the time being in force if needed. The ground of failure of contraceptive has been extended to women and her partner. This is all to ensure safe termination of pregnancy practices and increase the accessibility of termination of pregnancy to all women so that we will be able to reduce morbidity and mortality. The next one. So these are the salient features of the law. Now, what are the rules that have been framed under the Mtp Amendment 2021 Act? The rules defines special or vulnerable category of women eligible for extended gestational period for termination of pregnancy from 20 to 24 weeks. It also defines the norms for registered medical practitioner, at what gestational age, how many registered medical practitioners should be giving the opinion for termination of pregnancy, and also defines the roles and functions and powers of medical body, which includes a OB/GYN practitioner, a pediatrician, and a radiologist, and if any other specialist needed. These medical boards have to be formed by the state, as health is a state subject, and state is mandated to provide timely evidence-based decisions. Next. Next. So under the new rules, who comes under the special category of women who are eligible for MTP between 20 to 24 weeks of period. Remember, I was mentioning that the gestational age limit has been raised to 24 weeks for vulnerable women. So who comes under these vulnerable women? Survivors of sexual assault or rape or incest, women with pregnancy in humanitarian settings such as disasters and emergency situations as declared by government, change in marital status during the ongoing pregnancy, say suppose the woman loses a husband or it becomes a divorcee, women with physical disabilities as defined by the Disability Act, major disability as per criteria under the Disability Act, mentally ill women including mental retardation, minors. The last group of pregnant women who fall under the category of mothers who are carrying fetal malformations. Fetuses with fetal malformations. Now, these women can be safely with two RMPs we can do termination of pregnancies till 24 weeks, but after 24 weeks again we have to seek help from the medical board. So these are the vulnerable group of women as defined by or in the rules framed by the new Mtp Amendment 2021 Act. The next slide, please. So what are the rules? The second rule made by the Mtp Amendment 2021 is what constitute an RMP, who is a registered medical practitioner. So 20 weeks, up to 20 weeks, one registered medical practitioner opinion will be enough. From 20 to 20 weeks, you need opinion from 2 registered medical practitioners. And if it's beyond 24 weeks, if it's necessary for termination of pregnancy, you need to seek help from the medical board. Now, RMP, norms for the RMP, registered medical practitioners. Our RMP is defined in the old Act. Let us look into the old rule first. RMP is defined in the old Act as MBBS or more with any who is a medical practitioner assisted in 25 cases of MTP of at least 5 done independently in a hospital. Medical practitioner who has completed 6 months of house surgency in obstetrics and gynecology. Medical practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology, and medical practitioner who has experience of at least 1 year in the practice of obstetrics and gynecology. Now, this is one RMP. So, one such RMP till 20 weeks, 2 RMPs from 20 to 24 weeks, and beyond 24 weeks, it's a medical board. The next slide. So, I think there are other slides. There are some other slides. I think you are doing with the bold one. So, under the new MTP amendment rule, an additional category of provider has been added. For termination up to 9 weeks with medical methods, an RMP with experience in practice of obstetrics and gynecology at any hospital for 3 months, or training with performance of 10 cases of MTP by medical management under supervision of an RMP in a hospital established or maintained by a training institute approved for this purpose by the government. Now, these 2 categories are only for medical methods of termination before 9 weeks. I think this is the old PowerPoint presentation. There are some modifications in the new one.
That could be possible. Did you download the latest one from the...
Yeah, from the drive. I'm just watching it on the drive now.
Okay, 1 minute. Were you trying to play it from the drive? Is it?
Pardon me?
Were you trying to play the PowerPoint through the drive, or you downloaded it?
I downloaded. Just now I have downloaded.
Maybe that could be the reason why it was not working earlier.
I downloaded.
Okay, no worries. Hang on a second, please. Actually, I'm into 3 sessions right now, parallelly. And this was not something which I had envisaged that I have to run these slides. Yeah, is my screen visible now? Is this the one which you're referring to?
Oh, yeah.
Yeah, carry on.
So under the new amended rules, for terminations of up to 9 weeks with medical methods, RMP with experience in the practice of obstetrics and gynecology at any hospital for 3 months, or training with performance of 10 cases of MTP by medical method under supervision of a registered medical practitioner in a hospital established or maintained by training institute approved for this purpose by the government. So one RMP, this is only for 9 weeks, below 9 weeks, termination of pregnancy by medical method. The next slide. Now, the norms for RMP, whose opinion is required for termination of pregnancy, vary at different gestational age. Till 9 weeks, experience and training requirement for RMP, experience at any hospital 3 months or 10 cases of MTP by medical method, as I have mentioned earlier. The second group is a practitioner who has assisted an RMP in the performance of 25 cases of MTP, of which at least 5 have been done independently in a hospital. The third group of practitioners is a practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology. The fourth category is a practitioner who has completed 6 months of house surgery in obstetrics and gynecology, and 5 is a practitioner who has experience at any hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. Now, all these are till 9 weeks, and this is one opinion of one registered medical practitioner. Now, from 9 to 12 weeks or up to 12 weeks, the experience and training requirement for a registered medical practitioner includes a practitioner who has assisted and a registered medical practitioner in the performance of 25 cases, the same rule as before, and a practitioner who holds postgraduate degree or diploma, a practitioner who has completed 6 months of house surgery, and a practitioner who has an expertise or experience in a hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. And till 12 weeks, opinion of one registered medical practitioner is required. Now, beyond 12 weeks till 20 weeks, what are the requirements of experience and training for registered medical practitioner? A practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology, a practitioner who has completed 6 months of house surgery.
Are you in which slide, ma'am?
I'm moving.
Ma'am, in the Zoom you see and read, ma'am, because.
Okay, the next slides.
This slide, ma'am.
No, the next one. Next. So this is what I was talking about, 12 weeks experience and one registered medical practitioner. The next slide. So this is between 12 to 20 weeks. The experience and training requirement for registered medical practitioner or a person who holds a degree or diploma in post-graduation in obstetrics and gynecology, a practitioner who has completed 6 months of house surgery, or a practitioner with an experience of at least 1 year in a hospital with the practice in obstetrics and gynecology. Now, till 20 weeks, it's only opinion of one registered medical practitioner which is required. Next slide. So from beyond 20 weeks till 24 weeks, now the same criteria of registered medical practitioner who has a degree or diploma in obstetrics, 6 months of house surgery in obstetrics and gynecology, or 1 year experience of practice in obstetrics and gynecology. But here, opinion of 2 registered medical practitioners is needed from 20 to 24 weeks of gestation for termination of pregnancy. The next one. Now, beyond 20 weeks, experience and training requirement for registered medical practitioners are a practitioner who holds a postgraduate degree or diploma in obstetrics and gynecology. Number 2, second group are a practitioner who has an experience at a hospital for a period of not less than 1 year in the practice of obstetrics and gynecology. Now, the opinion of medical board is required for termination of pregnancy beyond 24 weeks. When advised by medical board, should be carried out with all safety precautions. Along with appropriate counseling and an appropriate place, and it is duty of medical board to ensure that there is a safe abortion facility available for that patient. Next slide. So what is the composition of a medical board? What is the rule 3 is the medical board, formation of medical board. So what are the composition of the medical board? A basic composition includes a gynecologist, a pediatrician, a radiologist, or a sonologist. Next. So what are the parts of the medical board? The parts include a medical board can allow or deny termination of pregnancy beyond 24 weeks of gestational age, only after due consideration and ensuring that the procedure would be safe for the woman and at that gestational age, and whether the fetal malformation has substantial risk of it being incompatible with life, or if the child would be born with serious mental and physical disability as indicated based upon the ultrasound findings. Whenever needed, medical board can co-opt other specialists. Say, like for cardiac abnormality, they can involve pediatric cardiologists. For renal abnormalities, they can involve a pediatric nephrologist. Co-opt other specialists in the board and ask for additional investigations or information if required before deciding on termination of pregnancy. Now, Foxy is working with ministry towards formation of medical boards, and as formation of medical board is a state subject, each state has to form their medical boards, and it's likely that in the next few months, all the states will be forming medical boards, and likely that medical boards list will be there on the Foxy website. Next. So, what are the functions of the medical board? Whenever we see a patient and refer the patient to the medical board for approval for medical termination of pregnancy after 20 weeks, they would first examine the woman and her reports who would approach for the medical termination of pregnancy. They provide the opinion of medical board on Form B with regard to termination of pregnancy or rejection of request for termination within 3 days of receiving the request for medical termination of pregnancy. They would ensure that the termination procedure, when advised by the medical board, is carried out with all safety precautions along with appropriate counseling within 5 days of the receipt of request for termination of pregnancy. So they have to provide their opinion within 3 days, and they should ensure that the termination is carried out within 5 days. This is all to avoid delay in the performance of termination of pregnancy. Next. So this is just an overview of the Mtp Amendment Act 2021. Any questions we can take, or please put it on the chat box. Thank you.
Yep. Sorry, apologies.
I'm sorry for this.
Yeah, I know it is one of those days when, there are several things happening parallelly, and technology also gives you the kind of challenges that we have witnessed today. But I guess we have all learned to live with these things, and it really doesn't hassle you. Thank you very much, Bashir, for taking over and walking us through these slides. I'm glad you were able to locate them on the Gmail account. Can I request, if Atima is, Atima is there.
Yes, sir, I'm here.
Yeah, are you able to show your slides and walk us through the next presentation, please? Okay. And before we get into the presentation, okay, are there any questions here? Who forms the medical board? Okay, that Uma, you have replied that. That's wonderful. Yeah, thank you. I think besides that, there are no other questions right now. But keep putting your questions here so that we can take them at the end of the session or at the end of the entire session.
I just want to tell you one point. Till the medical boards are formed, you can't just do Mtp saying that, it's legal now or beyond 24 weeks. Unless you have a medical board in a state where you can approve, where you can apply for permission, you have to take the legal route. You have to still go to court for termination if it's beyond 20 weeks.
Yeah.
24 weeks. 24.
Yeah, there are 2 parallel programs happening. 3, in fact. I don't know. She's not logged in there also, because that login, she can't log in because we haven't sent her that login. Yeah. And she had confirmed it also. How can that be possible? It has been sent to her twice. I have personally seen to it. 1 minute, we'll just have it sent again. Is she on the call? Okay. Yes, because she's not logged in. That's why you can't see her, I guess. Yeah, the link has been sent to her. No, no, I'm very much there. I'm on both the programs. I'm parallelly. I'll address here also. I'm addressing there also. No, no, no. It has Priya had volunteered, and let me just check with backend because I personally have looked at faculty. No, no, no. She doesn't have to speak there in Uma's program. She has to
You
speak.
can start, ma'am.
Yeah. She 1 minute. Let me just see. Has she left this? What is it? No, I don't see her here. She must have just left, is it? No, I don't see her name here. Earlier also I didn't see her name. Okay, 1 minute. Let me just, I'll just talk to backend. Let me talk to backend here.
Ma'am, you can start, ma'am.
Okay, a very good afternoon to all. So I'll be talking on safe abortion. By now, after hearing Dr. Uma, you all must be aware that the amendment that has been made recently is very women-friendly. So SAVER is a tool that has been adopted by WHO, and this acronym means Safe Abortion Values, Evidence, Rights, and Respect. This initiative is a collaborative effort by joint FOXY and WHO, and we all need to understand how important is respectful abortion care by providing our services to the women. So this module aims to define respectful abortion care by WHO standards. It will also highlight how norms and stigma adversely affect the services provided by healthcare providers. Provides WHO saver resources for respectful abortion care. Now, what is respectful abortion care? This has been adopted from respectful maternity care. Lots of evidence and research had been done because of disrespect shown to the mothers, and our country ultimately came to the point of respectful maternity care, and respectful abortion care forms an integral part of it. Now, what does it refer? It refers to the care that maintains safety, dignity, confidentiality, ensures freedom from harm and mistreatment, and enables informed choice and continuous support during and after all types of abortion, whether it is spontaneous or induced abortion. So in simpler terms, it means respectful care by providing services. You as a provider and or as a patient treat and are treated with dignity, empathy, and compassion regardless of your race, ethnicity, gender, socioeconomic status, or reproductive history. We are not here to question them. So how many times you have been pregnant? Or how many miscarriages did you have? Or how many times you went for abortion? This is for us not to judge. And if you ever feel that something isn't right, speak up. But as a health professional, it is our duty to listen and support them at every step. And for that, communication is the key to develop a rapport with the patient. So what are norms and stigma? Norms and stigma are not above law and policy. We as healthcare providers need to follow the law and policy that has been adopted by the government. So I'm going to show a short video over here.
Atima, we are not.
Yes,
You're
sir.
not audible. The video is not audible. Maybe you'll have to do a commentary behind it. I think so.
Video is not audible, sir.
No, it's not audible.
Have on our actions personally and
Bashir, can you help, please?
Ma'am, first up, share screen stop करो.
You stop the share screen, Atima. Yeah, we'll play it
When
from here.
when you click the share screen button, no ma'am, in the bottom there is one option is there, share sound and optimize for a video clip. Just you click that one, and after that you share the screen.
Okay.
And make it slideshow mode.
Women who have had an abortion once would become habitual and
Can you
avoid
hear
using
now?
contraception.
Yes ma'am, yes ma'am.
We can hear you.
Important to understand that norms and stigma are different from laws and policies. For example, an unmarried girl seeking abortion is considered immoral due to stigma, whereas, as per law, Sex-selective abortion is illegal in India. In this exercise, we explore how social norms and stigma influence access of reproductive health and rights, how people experience SRH stigma, the impact social norms and stigma have on our actions personally and professionally, and the impact they have on the actions of others, personally and professionally.
So stigma and norms, they perpetuate disrespect and abuse. And there are 7 categories of abuse which has been defined by WHO. So physical abuse like slapping the patient or intimidating physically, verbal abuse, shouting and screaming at her, sexual abuse, taking advantage of power, and stigma and discrimination, which you saw in this video. Failure to meet professional standards of care. If there is a poor rapport between women and providers due to lack of communication, and healthy system conditions and constraints. So these are the 7 categories of disrespect and abuse which should be avoided, because every woman has a right. She has a right to freedom from harm and ill treatment, right to information. She's protected under the Mtp and POCSO Act. Informed consent and refusal, she has the right. So we need to respect her choices, her preferences, dignity, and quality of care should be provided. She has the right to timely health care and to attain a highest level of health, liberty, autonomy, self-discrimination, and freedom from coercion. So these are 12 domains of respectful abortion care, which has been taken from respectful maternity care, best practice and research, clinical obstetrics and gynecology. Number 1 is being free from harm and mistreatment. Maintain the privacy and confidentiality of the women. Maintain her dignity. Accept her choice. Engage with effective communication. These are soft skills which we need to develop. Providing information and seeking informed consent. Ensuring continuous access to support. Enhancing the quality of physical environment and resources. Providing equitable abortion care, no matter she's rich or poor. Availability of competent and motivated providers. Contraception advice is very important, which should be given, and counseling and care should be provided before and after abortion. So there is again a short video.
No woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity,
Yes, you can make it
and
full
respect.
screen. We can hear you.
WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Seva, which no woman should die due to an unsafe abortion. And when abortion is provided, it should be given in a legal and evidence-based manner with quality, safety, dignity, and respect. WHO has a toolkit on safe abortion values, evidence, and rights, or WHO Seva, which is a module-based training for doctors, nurses, health providers, program managers, and really anyone to assess our values, address our biases, and learn together to transform our attitudes towards respectful abortion care for anyone who needs it. During the COVID-19 pandemic, we adapted and converted the WHO Seva Toolkit into an innovative, gamified, hybrid version that you can do either in person, online, or as a combination with an expert trainer or simply by playing one of the standalone games to learn from the comfort of your home. Saver has 4 modules: Engage, Inform, Explore, and Equip. In the Engage module, participants review recent media stories from the country about gender, unintended pregnancy, the realities of safe and unsafe abortion, and juxtapose these with the global standard definitions. In the Inform module, participants share and discuss background information on SRHR, on safety of legal abortion, contraceptive prevalence, abortion incidence and safety, abortion law and safety, and achieving reproductive rights in the global and regional or local context. In the Explore module, participants will play various games and watch videos relating to gender, safe abortion, preventing unwanted pregnancy, explore social norms and values, and consider how these may be rooted in stigmatizing attitudes or contribute to stigma from a personal perspective. The Equip module is to promote knowledge of, interest in, and further use of WHO guidelines and tools, with a focus on guidelines and tools relevant to contraception, abortion, and post-abortion care, towards the many steps needed for achieving the Sustainable Development Goals, also known as SDGs, building resilient health systems for universal health coverage, or UHC, leaving no one behind. We must remember quality and dignity of care matter as much as saving lives. Saver is our small step towards SDGs, starting with ensuring safe abortion is provided with values, evidence, and rights or respect.
So this was a short video on 4 modules to train the doctors, nurses, and the managers, whoever are involved in providing care. Now there is another video on a guide to avoid stigmatizing language.
How to talk about abortion, a guide to right-based messaging. Abort a child is medically inaccurate as the fetus is not yet a child. Terminate a pregnancy is commonly used. However, some people prefer to avoid this as terminate may have negative connotations for some people. For example, terminator or assassinate. In some contexts, the word abortion can be perceived as negative. In these situations, it may be helpful to avoid the word completely and use termination of pregnancy instead. It is important to be legally accurate, and in India, abortion is legally permitted to the full extent of the law. However, in many parts of the country, the barriers to access may be so great that abortion is considered by many to be illegal due to conflations with other laws. Make sure that you share accurate information about the legal situation and make the circumstances under which abortions are legal clear. See the WHO Global Abortion Policies database for information on the legal status of abortion across the world. Let us look at some stigmatizing words and how to avoid them. Abortionist is a term used by those opposed to abortion. Healthcare provider is usually a more accurate term to use than abortion provider, as most of those providing abortion care also provide other health services. In India, they are also called RMPs or Registered Medical Practitioners. The preferred terms are medically accurate as the embryo or fetus is not a baby. When referring to the tissue examined following a surgical abortion, an appropriate term is products of conception. However, this term is only useful for materials focused on medical details of abortion, as it is not commonly used or understood outside of medical or scientific contexts. Conscientious or moral objector implies that those who do provide abortions are not conscientious individuals, which is incorrect. Refusal to services must be well founded. For example, sex selective abortion in India is illegal. This tends to suggest an act of wrongdoing placing unwarranted blame on the woman and frames parenthood as punishment. The right to abortion should never be linked to how or why a woman becomes pregnant. Abortion is a woman's right and choice. Consider the classification of pregnancies into the categories unintended, unplanned, unwanted, or mistimed. The classification relies on a framework that assumes that pregnancy is, should be, or even can be a conscious decision. The complexity and possible ambivalence of pregnancy intention, as well as the dynamic nature of childbearing decisions before, during, and even after pregnancy, are not accommodated in these classifications. The suffix side denotes killing, which is not appropriate when describing abortion. When referring to sex selective abortion, it is more accurate to describe the practice in terms of choosing to end the pregnancy based on the predicted sex of the fetus. Make it clear that abortion is about making an informed decision and avoid the implication that ending a pregnancy is done without careful thought or consideration. The term keep implies a positive outcome which may not accurately reflect the situation. In addition, it is medically inaccurate to describe the pregnancy as a baby or child. It is more accurate to describe the situation as a pregnant woman choosing to continue with the pregnancy. Late term could refer to any time in the second or third trimester. Instead, if necessary, use terms that indicate the specific trimester or gestation. Use of late may also imply that a woman is late and thus irresponsible in seeking an abortion. For example, there is no gestation limit for birth defects and associated abortions in India as per the recent Mtp Amendment of 2021. Use of mother, father, parent during a pregnancy is value laden and assigns roles that the man or woman may not accept. It also implies that the fetus is a child, which is not accurate. Also, under the MTP Amendment 2021, in India, any woman and her partner, married or unmarried, can seek abortion. Abortion is not contraception. Contraception is to prevent a pregnancy, whereas abortion is to terminate a pregnancy. People often seek abortion due to the occurrence of an unintended pregnancy or for health reasons, and there will always be a need for safe and legal abortion. All reproductive choices and care should be available and supported. People should be supported to prevent unintended pregnancies with access to contraception and accurate information. Pro life implies that those who support legal abortion access are anti life, which is inaccurate. Instead, use alternative terms to make it clear that you are referring to individuals opposed to anyone having an abortion. Where possible, our language should reflect the fact that we are service providers with a focus on providing rights based quality healthcare and support. In order to dispel myths about organizations that provide abortion care, it might be useful to avoid business related language. Multiple and repeat can have negative connotations, such as repeat offenders. Multiple and repeat also imply that each abortion experience for a woman is the same, whereas each abortion is surrounded by a unique set of circumstances. If safe, what is wrong with having multiple abortions? Because abortions happen under a wide range of cultural, legal, and medical circumstances, it is important to be careful about the terms that you use to avoid mixing up terms and creating confusion. Here are a few phrases to be aware of. Illegal abortions are those that do not comply with a country's legal framework but may be safe if performed by a trained provider or when a person has access to high quality medication, information, and support to safely undergo a medical abortion in a safe and licensed place. Remember, abortion is considered safe as per WHO guidelines when the three P's provider, place, and process are safe, trained, and certified. Unsafe abortions are performed by providers who are not registered or trained, or in situations where people are unable to safely undergo a medical abortion due to lack of access to high quality medication, information, or support. It is possible to have an unsafe legal abortion. Unwanted pregnancy is a pregnancy that a person decides they do not desire. Unplanned or unintended pregnancies refer to pregnancies that occur when a person is not trying to get pregnant. An unplanned or unintended pregnancy may be either a wanted or unwanted pregnancy. In India, abortion is legal, but sex selective abortion is illegal. Provider and place need to be safe, trained, and certified.
So this was the video on how to avoid stigmatizing language, because sometimes the terms we use, it is a stigma for the women. For example, abortion should be replaced by the term termination of pregnancy. So now the law has changed, and for the dissemination of law, this needs association of obs and gynae provider support. Oxy is the largest provider base for abortion care. During COVID, we saw that it was a great disaster for all of us. But the advantage was that online training was possible during the COVID period. We had a number of webinars, and that certainly added to our knowledge. Medical method of abortion uptake has also increased. It is early, safe, and ensures no PCP and DT conflation. So it is the safety, respect, and quality that matters more than ever. And we have a very significant role to play. Now, time has come to strengthen the implementation of the new law. Every patient is an opportunity for respect. And as providers, onus is on us to educate and also reduce sex-selective abortion. By now, you all are aware that up to 20 weeks of gestation, opinion of one RMP is required. So there will be more responsibility on the provider. Counseling, contraception is important, and if necessary, the women can be referred, and compassionate care should be provided every time. If the gestational age is from 20 to 24 weeks, then opinion of 2 RMP will be required. No women should be refused abortion up to 20 weeks of gestation. And from 20 to 24 weeks of gestation, there is a special category of women, like rape victims, unmarried women. Everybody needs unbiased care, and we need to overcome our own biases first. 20 to 24 weeks of are special cases. Even women who are out of marriage, like those who are divorced or are widowed, they need special care with sensitivity, judgment-free, and timely services should be given to them. Confidentiality should be a priority. Respect begets respect. So as providers, we need to be very mindful of socio-cultural aspects. So from 1970, it was a time of unsafe abortion. We moved on to safe abortion in 2000. And now we have moved to a very new concept from 2020, that is respectful abortion care. So there are now some questions for you. You'll get 30 seconds to answer. You can answer it on your chat box, or you can raise your hand. So number one, according to the World Health Organization, restriction access reduces the number of unsafe abortions. Is it true or false? So the answer is false. When you consider abortion safe, when both the criteria are met by appropriate method as well as by trained persons. If one of the criteria is not met, then it will be less safe. And if both the criteria are not met, then it will be unsafe abortion. So the next question is, the Mtp Amendment 2021 requires a minor less than 18 years to obtain written consent from parents, guardians, before she can undergo a termination of pregnancy. So whether it is true or false. So you all have answered true, but actually the answer is false, because anyone who is adult more than 18 years of age can give a written consent. Parents or guardians' consent is not required in this amendment. But sure, POXO reporting is still needed, and abortion services should not be denied at all. We need to provide bias-free services without judgment. Now, third question. 30-year-old woman, recently widowed, wants to get an abortion at 22 weeks. As a provider, it is your responsibility to tell her to continue this pregnancy. Yes or no? So all of you all have answered correctly. No, because we don't need to be judgmental. It is our it is not our responsibility to tell them to continue this pregnancy. It is for her to decide. And since she's 22 weeks, so opinion of 2 registered medical practitioners will be needed here. So in the end, I want to say that all of us should change our mindset. Law has changed and we need to change our mindset as well. And so let us take a pledge to make abortion safe, respectful, and at the same time, maintaining the confidentiality of the women. Because all of us know that unsafe abortion is a third leading cause of maternal mortality, and 8% of MMR is due to unsafe abortion. So let us all together make India a Samarth Bharat. Samarth is an acronym for safe abortion made available respectfully throughout the health system. So I would now like to thank honored President Dr. Shanta Kumari, who's so passionate about women's health. And I think this training will certainly be a step forward in improving the women's health. And I would also like to thank Dr. Ajay Bhardwaj for taking tremendous effort in making this training possible. So thank you, sir.
Thank you so much, Atima. It was lovely seeing you after so long, and a wonderful job done. We will, the question answer session that you posed of true and false was very interesting, because I can see in your second question, a lot of people got it no, you know, and the first one also, a lot of people got it false, false, false. So I think which is a good thing in terms of whatever we are trying to propagate here and take it forward. We will call in Surya Kumar. Are you able to present?
Good afternoon, sir. I'm unable to share my screen through Zoom. There is a problem with my laptop. Can you able to share somebody to
Yeah,
share
I will
the screen?
request backend team. Is it possible? Can you play the share screen for the next presenter? And Oma, as
I'm here.
requested, you please take over from here.
Yeah, sure, definitely.
I will be in the background.
Yeah, sure, sure.
This one only.
No.
3A.
No. This is
Not
the
this one, 3A, the abortion, safe abortion. Next one.
Not this one.
Escape, open the. No.
No,
No.
not this one either.
3A. Updates.
Safe
Yeah,
abortion.
3A.
So this one.
No, not this one.
It's
No.
3A.
The numbering may be a little off, Bashir. I will tell you. Open your file. Yeah. No, you have not downloaded it, Bashir. That's number 2 over there. Just download it, please. If you have. No, it's not here.
It's number 2.
Yeah, it's number 2.
It's number 2 on Google Drive.
Yeah, that's the one.
Yeah.
Okay. I am audible?
Yes.
I am audible?
Yes, Dr. Suryakumar, you're
Yeah.
audible.
Thank you. First of all, I thankful to our president, Oxy, and Dr. Ajay Bharadwaj sir for giving me opportunity. As we have driven through Mtp amendments and saver module, now we move with module number 2, that is safe abortion updates in technology. Now it is stated, it is called as respectful abortion care, a joint Foxy and WHO initiative. Next slide, please. This session will consist what are the existing guidelines, what are pre-abortion assessment, what are the medical methods of abortion and surgical methods of abortion. Next slide. Next. This is WHO global guidelines on safe abortion. This slide shows that safe abortion about technical and policy guidelines for health system, medical management of abortion, safe abortion care and post-abortion contraception regarding. Next slide. This is and previous slide are similar since 2012 to 2019. What are different changes had gone through, and with help of WHO National Publication on Safe Abortion. In 2012, there was technical policy guidance for health system was published. In 2014, there was a clinical practice handbook on safe abortion published. In 2015, role in providing safe abortion care and post-abortion contraception. 2018, the medical methods of abortion guidelines was introduced. In 2019, the guidelines on safe care intervention for health system. Next slide. This is important slide. Landmark has been in MTP. Law changed on 25th March 2021 and rule was introduced on 24 September 2021. Next. All guidelines have 3 key areas in management of abortion safely. These are pre-abortion care, abortion care methods, aftercare, and follow-up, including post-abortion contraception and counseling. For decision making, we have to take a proper medical history, physical examination, laboratory investigation if required, and discussing the contraceptive option. Next. Pre-abortion assessment and counseling. Next. What are the components for pre-abortion assessment for a woman seeking first time abortion? Already I mentioned that you have to take a proper detailed history. You have to do a thoroughly general and physical and pelvic examination, laboratory and other investigation as per requirement, decision making, information on abortion procedure and counseling. Next. That up to 4 weeks, after 4 weeks, uterus start enlarge in a side. After 12 weeks, uterus become an become an abdominal organ, and at 20 weeks, the uterus reaches up to the height of umbilicus, and after 20 weeks, it symphys the fundal height correlates with weeks of gestation. But there can be discordancy between the uterine uterine on bimanual examination or size because of uterine fibroid. Just a minute. Because of there is a malformation because of fibroid, multiple gestation. Previous slide, please. Previous one. Yeah, thank you. There is a the uterine height might be enlarged because of uterine fibroid, malformation, multiple pregnancies, uterine retroversion, obesity, due to inaccurate menstrual dating. Patient might be non-pregnant, or we have to rule out the ectopic pregnancy when uterine size is smaller than expected. If uterine size is more than the expected, you have to think about inaccurate menstrual dating, multiple gestational, uterine fibroid, and molar pregnancy. Next. Next one. Pre-abortion immunization. These routine lab tests not mandatory. Test may be performed as per individual risk factor on finding on physical examination. We have we have to confirm the pregnancy, hemoglobin or hematocrit if we are suspecting anemia. RH typing is must. If she is RH negative, we have to give her anti-D. HIV testing. Then we have to screen for sexually transmitted infection. We have to screen for other medical history. Ultrasound is not mandatory, but it whenever there is suspicion of ectopic pregnancy or missed abortion, it might help us. Next. Next, please. Pre-abortion counseling. These consider three components: ask, inform, and document. In ask component, thoughts about terminating the pregnancy, a reason why she is terminating the pregnancy. Inform, early abortion is a safe, importance of trained provider, provider performing the procedure for safety, available methods of abortion, risk and warning sign associated with abortion methods. Without contraception, she can get pregnant as soon as 14 days after an abortion. This has to be informed her very well. Resumption of her normal activity, including sexual intercourse. In any other follow-up, we have to consider. In documentation, you have to inform written consent has to be taken. Decision to accept post-abortion contraceptive. We can't force it, but we can take an advantage and to make her aware about the contraception and try to make her ready to accept her some method of contraception. Next. Clinical management of abortion. Abortion care for less than 12 weeks include combined mifepristone, misoprostol, or vacuum aspiration. Vacuum aspiration can be manual or electric. After 12 weeks, we can either go for a combination of mifepristone and misoprostol, or DNE. DNC should not be done. Next.
Please unmute.
Hello. Next. I am audible? No,
Yes, sir.
slide.
Yes, sir.
2-3 slide has gone. Tablet, mifepristone and tablet misoprostol. We know that mifepristone is the anti-progestin. It inhibits action of progesterone. Because of this, it will interfere with continuation of pregnancy. Initial oral dose of mifepristone should be followed by misoprostol, which is the prostaglandin E1 analog. Misoprostol causes cervical softening, uterine contraction, and then expulsion of products of conception. Next slide. This slide shows that on day 1 we have administered mifepristone in a dose of 200 milligram. If mother is Rh negative, we have to do anti-D on same day of 50 microgram. We have to make her follow up on day 3 for misoprostol administration. Up to 7 weeks we can give 2 tablets of misoprostol, either sublingual, buccal, vaginal, or oral. For a pregnancy between 7 to 9 weeks, 800 microgram dose can be given sublingual, buccal, vaginal. If patient is, we have to had any problem like severe pain, vomiting, we can go for analgesic, antiemetic, and make a counseling on contraception. Within days of 15, follow-up is required to confirm completion of procedure and counseling about contraception method acceptance. Next slide. This is a diabetic presentation. In case of buccal, we have to keep the tablet between the teeth and cheek. In sublingual, we keep the forehead below the tongue. Next slide. WHO drug regime dose schedule for medical abortion already introduced. Induced abortion for less than 12 weeks, mifepristone 200 milligram per orally, or misoprostol on day 2 or day 3, either buccal, vaginal, or sublingual 800 microgram, that is 4 tablets. You can only use misoprostol in dose of 4 tablets, that is 800 microgram, either buccal, per vaginal, or sublingual. Vaginal bleeding for 2 weeks is a normal after medical abortion. Such bleeding can last up to 45 days. In rare cases, we have to make aware the patient while we are prescribing medical methods of abortion. Next slide. Provision of medical methods of abortion services. Services should be available at primary care level with a referral system in place for all required higher level care. Additional service may need to provide to individuals seeking medical abortion. Counseling, testing for sexually transmitted infection, abuse support service, psychological or social services, other specialist health or medical services, provide iron tablet if for anemia if required, provide any necessary pain medication, provide emotional support if needed. Next. Follow-up care. Routine follow-up care of not necessary following an uncomplicated medical abortion using mifepristone and misoprostol. A follow-up up to 7 to 14 days after the procedure may be offered to provide a contraceptive counseling and services, emotional support, or address any medical concern. A routine follow-up visit is recommended only in case of medical abortion. Misoprostol alone method is used. Next slide. Follow-up care. Assess woman recovery and ask for any signs or symptom of ongoing pregnancy. Review any available medical records and referral documents. Ask about any symptom experienced in the procedure. Perform a focused physical examination for any complaint. Assess woman fertility goal and need for contraceptive services if not provided earlier. Then we come to the summary of medical methods of abortion. This is same on day one. We will go for physical and pelvic examination, confirm the eligibility criteria for medical methods of abortion. Now it is changed up to 9 weeks. Tablet mifepristone I already informed. Next slide. Next. Important thing is that 3% women may expel completely with mifepristone alone, but misoprostol should be completed. If we are using only one method, we have to make an assurance that complete abortion has been occurred or not. You have to confirm it. Next. One slide, please. Backward. What are the side effects and complications? Next slide. There can be pain, nausea, vomiting, diarrhea, and infection. In pain, there may be respectful or non-judgmental communication. Verbal support is required. Adequate counseling is needed. Support person, you can go for analgesic like ibuprofen 400 milligram. If pain is persistent, failure to respond to the drugs, then we have to think about ectopic pregnancy, infection, or incomplete abortion. Nausea and vomiting is a self-limiting. We have to make her reassure her only. In infection, we are confirmed by physical examination and we have to require some time antibiotics. Next slide. What to be done if the medical method of abortion fail? Failure of medical methods of abortion, we can go for offer vacuum aspiration or we can repeat a second dose of medical methods of abortion. If it is a case of failure, in case of incomplete, we have to observe her unless heavy bleeding is there. We can repeat misoprostol or we offer a surgical methods of evacuation. If we have to go for assess her bleeding, assess her the normal uterine size. If there is bleeding is heavy, we can go for a surgical method, that is electric or manual vacuum aspiration. If bleeding is resolved, then we have to assess her for abortion completion. Next slide. Recording and reporting of medical methods of abortion. Since medical methods of abortion come under the purview of Mtp Act, documentation is similar to that required for vacuum aspiration. It is mandatory to fill the form. We have to fill the consent form, form 1, that is register medical practitioner opinion. We have to inform in monthly reporting in form 2. We have to mention the name in admission register as a case record. Next slide. Next. Methods of first trimester abortion, surgical methods of abortion, that is manual vacuum or electric vacuum aspiration. Next. In surgical abortion method for first trimester, vacuum aspiration is recommended technique for surgical abortion up to 12 weeks. WHO recommends manual vacuum aspiration as the safest method. The procedure should not be routinely completed by sharp curettage. This is important. We have to not go for a sharp curettage. Next slide. As we are all familiar with vacuum aspiration methods, procedure of abortion is performed in the same regardless of the type of use, whether you are using manual or electric. In manual vacuum aspiration, a handheld aspirator is used to generate a vacuum. The syringe is shown in the diagram. Aspirator is attached to the cannula. It is available in 4 to 12 mm in a size. Cannula can be also used for electric suction purpose. In IPAS or easy grip cannula, the size of cannula correspond to the size of uterine, that is uterine size, there is a number of gestational. That means 8 mm cannula is correspond to 8 weeks of gestation and 10 mm for 10 weeks of gestation. Next. Next slide. We are familiar with this electric vacuum machine. Everybody having in their own setup. This is electric vacuum aspirator. An electric pump is used to generate a vacuum and accumulate the cannula of manual vacuum aspirator with correct size tubing. Silicone tubing will help us in electric vacuum aspiration. Next slide. Most important that we, in surgical vacuum aspiration method, we have to prime the cervix. Priming of the cervix not only easy help in easing dilatation of the cervix, but it prevents the complication. May be considered for women with a pregnancy of any gestational age to prepare the cervix and make it soft and easy to dilate. Recommended method of cervical preparation before surgical abortion in first trimester. Oral mifeprint can be given in a dose of 200 milligrams 1 or 2 days in advance, or we can put a misoprostol 400 microgram, give 400 microgram misoprostol sublingually 2 to 3 hours prior to the procedure, or we can put per vaginal 3 hours prior for the procedure. Laminar taint place intracervically 6 to 24 hours prior to the procedure. Next slide. How we can go for pain management in a vacuum aspiration procedure? Important component of quality abortion care, reduces pain and anxiety, makes woman comfortable. Two components of pain management are either pharmacological or non-pharmacological. Next slide. Next. Slide, please. In non-pharmacological pain management, psychological support is explaining the each step to woman in advance, performing the procedure gently and smoothly, encouraging the woman to relax and breathe deeply. Next slide. What are these? This slide explains the pharmacological pain management plan, source of pain and its management. Where in case of anxiety, we can give anxiolytic in form of diazepam or general anesthesia. If we are using anxiolytic diazepam can be given in a dose of 10 milligram orally 1 hour prior the procedure, or 2 to 5 milligram IV 20 minutes prior to the procedure. Duration of effect of diazepam is 4 to 6 hours. Side effect, we can think about disorientation and dizziness. In cervical dilatation, you can go for giving a local lignocaine or analgesic in form of ibuprofen. If you are using lignocaine, it has to give 10 ml of 1% lignocaine in form of paracervical block. It is action lasts for 60 to 90 minutes. If care has to be taken while inserting lignocaine, it should not go intravascular. It is a pro-arrhythmic drug, so we have to take a little bit care during that time. Side effect like dizziness, seizure, gastritis, we have to think. If we are giving analgesic, we can give ibuprofen in dose of 400 to 800 milligram 1 hour prior to the procedure. If there is uterine cramping, we can think of analgesic as ibuprofen, that same 400 to 800 milligram 1 hour prior to the procedure. Duration lasts for 4 to 6 hours. Side effect is gastritis. Next slide. Steps of medical vacuum aspiration. Next slide. First, we have to load the syringe. We have to create a vacuum. Then We have prepared the woman, ensure the pain control medication, as I already described, that of giving lignocaine 10 ml 1%. We have to ask the woman to empty the bladder prior to performing the procedure. Perform cervical antiseptic preparation, administration of paracervical block in form of giving lignocaine at a 4 o'clock and 8 o'clock position. We have to dilate gradually the cervix, and we have to insert, most important in inserting the cannula, that we have to not to push the cannula hardly. We have to be softly. Once we process the internal os, just little bit forward, there is no need to reach up to the fundus, because as the products are concession and been evacuated, the uterine are going to be decreases, and this will decrease the chances of forceful or chances of uterine perforation. Next slide. This is a documented presentation about the manual vacuum expression. Next slide. Fine. What are the size of empty uterine cavity? Empty. Red or pink foam without tissue passing through the cannula. There is gritty sensation over the surface of the uterus. There is a cervical gripping over the cannula. Uterus contracting around the cannula and increase uterine cramping. After we have completion of the procedure, we have to assess the tissue. Concurrent procedure, proceed with contraception methods such as sterilization or IUCD, or instrument procedure to be soaked in a chlorine solution for a disinfection. Next, please. What post-procedure care to be given? We have to monitor her for any complications, provide management as needed. They may leave the facility when she is stable or meet the criteria of discharge. Ensure that woman has all necessary information and medication prior to leaving facility. Documents all outcome of the treatment, including any adverse event in the facility register and client record card. Next slide. Aftercare. Management of abortion complication. We have to rule out incomplete abortion, infection, bleeding, ongoing pregnancy. Provision of contraceptive information and offer contraception counseling and different methods. Assessment of any other sexual or reproductive health need that may require additional care. Follow-up. No routine follow-up unless biso alone regime is used. This is a newer recommendation. If we are using only one method of medical abortion, we have to ask her to follow up. Next slide. In summary, India has made a historic progress in improving access to safe abortion. Not much has changed in technological update in last decade. As a provider, it up to us to ensure the safety and quality, especially in context of amended law. Along with the safety, we also need to focus on respectful abortion services. Every client, public or private, an opportunity to inform, educate, and equip with proper information and on contraception and counseling. Next slide. All participants should take a note that there is a pre and post test, and we have to give feedback on this. And henceforth, now we should call as a respectful abortion program rather than only safe abortion. Thank you.
Thank you, Dr. Surya Kumar. So, moving on to our next topic, it's about. Hello.
It's 3B.
Yeah. No. I'll try to share these.
I am audible?
Am I audible now?
Yes, yes,
Yeah.
ma'am.
Yeah.
Okay, yeah, good. So finally, yeah. So moving on, thank you, Dr. Surya Kumar, for wonderful discussion about family advocate procedures, the documentation that is needed, and the post-abortal care. Now coming to the now we move on with the fourth the final talk for the day or module for the day. I know after 2 hours of this grueling, it would be a tough task to learn about counseling and the aspects of counseling involved in post and pre and post abortion care. Now, in this module, I would be discussing about the pre and post abortion family planning counselings and how to use technology to adapt current and changing trends towards online consultations. So, what is counseling? How do you define counseling? Counseling is a structured interaction in which a person voluntarily receives emotional support and guidance from a trained person in an environment that is conducive to open sharing of thoughts, feelings, and perceptions. It's an important point here to notice that the patient will voluntarily come seeking help, and so there can be a form of open discussion to share her thoughts and feelings. What is pre and post abortion counseling? We should note that pre and post abortion counseling is integral part of comprehensive abortion care services and is as important as the procedure itself. The counseling should be focused towards helping women take decision about the family planning methods and if needed not a must note it, it's not a must to involve the partner, but if needed or whenever needed situation deems necessary, partners should be involved in counseling to maintain synergy and then move on with the decision making process. What is the pre-procedure counseling? Pre-procedure counseling should help women decide about termination of pregnancy, help women to choose method of termination of pregnancy once she made her decision about termination of pregnancy, let it be medical or surgical methods. And also, this counseling helps to ensure delivery of complete information about the procedure or the method chosen by the patient. And finally, the pre-procedure counseling helps women to adopt a contraceptive method after a counseling process. What is the procedure involved in pre-procedure counseling? Counseling should be, as I have mentioned, should be a patient comes voluntarily. It can be in single or as a couple, and please ensure that it is in a private area and only patient is alone with you to ensure privacy and confidentiality. We as doctors should not be judgmental and should be very sensitive to patients' needs and concerns, and all this in a way to establish rapport and build confidence in the patient. Always use plain, simple language, no medical jargons, and do your counseling in a way that you give some time to allow her to ask questions if there are any doubts to clarify from her side. And lastly, once decided on termination of pregnancy, the method of termination of pregnancy, assess her for the suitability of the procedure. And you can actually go into details, the risks, benefits, and complications of the procedure, and the suitability of the procedure during this counseling process. What is the relevance of pre-abortion, peri-abortion family planning counseling? The other issue, this is the most important issue apart from the abortion process itself to discuss during the time you get to talk with the patient. You have to inform her that there is a quick return of fertility. It can range from 10 days to 4 weeks after termination of pregnancy, and take this opportunity to build her confidence and motivate her to accept contraception. And you have to inform her that it is suggested that a minimum of 6 months period is advisable before next pregnancy, by explaining her about the health benefits and better pregnancy outcomes in her future pregnancy. This is for us to note that 90% of abortion-related maternal mortality can be prevented by ensuring contraception. And by now we know that women seeking contraception is beneficial in long term to avoid maternal morbidity and mortality. And so it's very important to discuss this aspect of contraception during a peri-abortion counseling. Now, pre-abortion family planning counseling. When should we start? You should start pre-abortion family planning counseling during her first visit or first consultation, except when there is a deep grief involved. In that event, you can delay a bit, but as most of the time women comes to seek abortion voluntarily, you can start with in the first visit. And what do you counsel? What are the aspects that are involved in pre-abortion family planning counseling? Counsel her about the quick return of fertility, help them choose the methods from the basket of contraceptive methods available, and also method-specific counseling. And whenever applicable, discuss about the high-risk behavior and increased chance of STIs and HIVs and all these. If the woman is not willing for any contraceptive method, do not refuse MTP. Try and counsel her after the procedure. If she is still not willing, call her for follow-up in a week's time and counsel her again. What are the general guiding principles or rules first to assess the sustainability of, suitability of post-abortion contraception? First, check whether the abortion process is complete, that there is no evidence of sepsis or no evidence of retained products of conception. If patient had gone through surgical method, make sure that there is no injury to the genital organ. And if there is a delay from your counseling or from your abortion to women seeking contraception, ensure that she's not with a fresh pregnancy again before you offer a contraception. Post-procedure counseling do play a critical role, and during this period, we should ensure woman has understood the precautions and the care needed to be taken during the post-abortion period. Again, take an opportunity to counsel her for contraception in case not previously accepted, and reinforce the need for continuing the use of contraceptive method chosen till she wishes to become pregnant. So during post-abortion counseling, it's the same procedure as before. Continue to ensure privacy and confidentiality, reassure her in case of any problems, and repeat the information about the post-procedure care and dangers, and then talk about contraception. Post-procedure family planning counseling, if she has already opted for any contraceptive method during the pre-abortion family planning counseling, just provide information, appreciate her, provide information as to when to use, when do you start, how to use, and a follow-up protocol should be explained to her. And if there are any questions and answers, do address her and give her some kind of patient information leaflets. If the patient has undecided about the method of contraception to be used, first allay her anxiety, explain, counsel her about the false beliefs and myths that are around her, and reassure her, about the safety of the various contraceptive methods, and explain to her and discuss the importance of immediate adoption of contraceptive method, and choose and how to follow. If whenever necessary, do extend counseling to the couple if deemed necessary. If the woman doesn't decide about the contraception, then do you explain about the emergency contraceptive pills? Now, what are the various post-abortion contraceptive methods available? We will just briefly go through the various methods currently available and when it can be started after each trimester termination of pregnancy, and any information which is additionally needed to be provided with each specific method of contraception. Talking about barrier methods, the commonly used barrier methods are condoms, and condoms can be used as soon as the sexual activity is resumed immediately after the first and second trimester miscarriages. Now you can discuss with the patient about the about that being not non-hormonal, can be used, immediately after termination of pregnancy, and has an additional benefit of prevention of sexually transmitted infections and HIV. But this has to be enforced that men should take the responsibility of this mode of contraception. The next contraceptive method available is intrauterine contraceptive device. Intrauterine contraceptive devices, any number, let it be 388, excuse me, let it be IUCD 375. It can be inserted immediately or up to 12 weeks after confirmation of abortion using the surgical method. Excuse me. Sorry. Intrauterine contraceptive device, whatever is the number, it can be inserted immediately or up to 12 days after confirmation of a completed abortion. This is after the first trimester using the surgical method. With medical method, insertion around day 15 of the process, provided complete expulsion is confirmed and risk of presence of infection or other contraindication is ruled out. After second trimester, termination of pregnancy, it can be inserted immediately or up to 12 days after the procedure is complete and contraindications, again the retained products or infection being ruled out. What additional information? You do explain to them the number of years she can use, 5 years in 375 and 10 years in 380A, it being highly effective, and no hormonal side effects, and can be provided by trained doctors, MBBS or ANM nurses after first trimester surgical terminations, and by trained doctors after medical method and postpartum IUCD, or trained by any trained doctor after second trimester miscarriage. Now, the third method of contraception is the hormonal contraceptives. In here, we are discussing about the combined oral contraceptive pills. The combined oral contraceptive pills can be started immediately or up to 7 days after surgical method of first trimester miscarriage. Termination of pregnancy. With medical management, it can be started on day 3 with the dose of misoprostol or within day 15 of the process after confirmation of complete abortion. Now, coming to the second trimester, after second trimester termination of pregnancy, combined oral contraceptive pills can be started immediately or up to 7 days after abortion. What additional information you need to provide is that it's not suitable for women who are breastfeeding because of the estrogenic effect. It do impact the quality and the quantity of the breast milk. But the good points you can inform them is that it regulates the menstrual cycle, provides protection against ectopic pregnancy, endometrial and ovarian carcinoma, benign diseases such as fibrocystic, and I mean to say you can provide the non-contraceptive benefits of oral contraceptive pills. And of course, there is no interference with the sexual activity, can be provided by any healthcare worker after first screening by the trained provider. Coming to the other hormonal contraception, say like injectables, depomedroxyprogesterone acetate. After first trimester miscarriage, it can be injected immediately or up to 7 days after surgical method. With medical method, it can be on day 3 with the dose of misoprostol. Or after second trimester miscarriage, it can be given immediately up to 7 days after miscarriage. After termination of pregnancy. Now, the additional information is that it's highly effective. Confidentiality and privacy is maintained. It can be provided by any doctor, Ayush, ANMs, nurses, and it requires once in 3 months for the first injection, no interference with cells, and more importantly, is no effect on the quality and the quantity of the breast milk. No estrogenic side effects, offers protection against ectopic pregnancy again. Now, finally, we have the permanent methods over here. The permanent methods of female sterilization is tubectomy and vasectomy. I don't think we need to go into details because this is what we have been doing for, tubectomies are happening and what the counseling aspects this remain the same after termination. They can be performed after the abortion in the absence of any infection or severe blood loss concurrently or up to 7 days with midi-lap. Same with second trimester losses, but you have to stress upon that it is a permanent method of contraception. And vasectomy is to be performed on males, and it requires much more counseling because of their myths and beliefs which are there because of the social and cultural backgrounds and the beliefs. So whatever the method they chose, you have to stress upon that it is a permanent method of contraception, and the failure rate involved with that. Now, this is just a recap of what we have gone through in the past 4 to 5 slides as to when you can start contraception and till when you can advise. COCs, injections, Encroman can be started on day 3 and can be given till day 15. IUCDs can be inserted immediately and can be given till day 14 to day 15, the same thing. Now, this is where the technology comes in what way? This brings us further to use of technology in sexual and reproductive health services. How can we utilize technology? By offering video consultations. COVID has taught us all this, on how to do teleconsultation, telecounseling, teleguidance, telereference, telelinkage. Now, everybody, most of the majority of the population is well versed with websites which give information about various problems, issues they face, and how to access telemedicine, teleconsultation. Most of them have smartphones. So obviously, we have to provide SRH, sexual and reproductive health services, contraceptive advisors through teleconsultation services. Now, a lot of helplines are available where patient just makes a phone and get some form of an advice from a doctor or a trained personnel regarding whatever health aspects issues they have. And also the many websites and where they provide lots of patient informational leaflets and educational guidance leaflets, say like ACOG or RCOG or WHO, and even Ministry of Health and Family Welfare, our own Indian government do provide, and there are a lot of infographics available. So with technology, most of the information is available over internet. And we should also provide some kind of teleservices so that the patient, it will be easy to access by the patient. A lot of logistics like travel from far away places can be reduced. But then what are the strengths and weaknesses of telecommunication or teleconsultation? I would put it teleconsultation. Strengths, yes, COVID era has taught us how important it is to stay away from in a group, and then how to be in a private space or individual space to take a consultation. It's appropriate, it's approachable and accessible. Patients can get confidence about accessibility. Definitely, lot of travel can be avoided. Being in a groups in a consultation area can be avoided. And now everybody is aware of the video consultations available in most of the places. The major weakness with this teleconsultation services is that obviously there is no face-to-face communication, and maybe majority some women might not be able to express all their questions through teleconsultation. And you can't demonstrate, as say, like how to use pills, or how to you can always search how do we insert a loop, or how to use pills in a daily basis, or how do you have to check your contraception. So some kind of demonstrations might not be possible, and of course, yes, face-to-face counseling is not possible. The major drawback is that. But one thing is, you have to take it ensures privacy and comfort, definitely. Cost saving, yes, decreases a lot of expenses and cut down the number of visits. But the major threat is, yes, we don't have a face-to-face diagnosis, we might have there might be a chance of misdiagnosis and missing an opportunity to thoroughly evaluate the patient. So what is the applicability of these teleconsultation services as a part of comprehensive abortion care, or sexual and reproductive health? First, maybe a kind of hybrid service will help. Initial visit, confirm diagnosis, discuss about contraception, demonstrate whatever you would want to demonstrate at that point, and further on a video consultation or either by WhatsApp or a Zoom call will be helpful, and then follow up as needed definitely reduces the number of visits to the hospital, and then you wouldn't miss an opportunity of misdiagnosing or missing an opportunity to assess a patient thoroughly, and you could demonstrate. So a kind of hybrid service is better for any as a comprehensive abortion care practice or safe comprehensive abortion care services and safe sexual and reproductive health services. Now, what is the key message is that we all know that there is a need for post-abortion family planning, counseling, and service, and it's very essential to reduce the number of unsafe and unwanted pregnancies, thereby reducing number of unsafe abortions, thereby reducing morbidity and mortality. Bring the couple on board whenever possible and strive for near 100% coverage. I don't know when we can achieve that, but yes, we all have to work forward, looking forward for that, towards that. Capitalize on all the available contraceptive methods available in the basket and its applicability in post-abortion period. As far as possible, use technology so that it will be easily accessible to the patient. And it's better we incorporate technology in providing abortion care services. But major concern by use of technology is the policy. Now I think we have a policy made on how to on what about that teleconsultation reduces. Sorry, there is a policy by a Medical Council of India on to what extent we can provide teleconsultation services. Now coming to malpractice, it's the onus is on doctors regarding malpractice, and we ourselves have to ensure that this malpractice part is not, there shouldn't be an issue at all. Obviously the cost will come down and it's more accessible. And obviously, as I have mentioned, both online and offline services or a kind of hybrid service is likely to help better for sexual and reproductive health, a wide coverage of sexual and reproductive health services and comprehensive abortion care services. And now I think with this, we have come to the end of this RAC training program for the day. Any questions you can post on the chat box and we can respond, or you can just mail. Don't forget that there is a post test and you need to do that to ensure that you get the certificate. So before you log out, you'll have a pop-up. Can you hear? Am I audible?
Yes, you are audible.
Yeah, so this brings to the end of the session. Any questions, please? So if any questions, you can post on the chat box. Do take our post test. Once you log out, there is a pop-up which shows, do you want to continue or do you want to exit? Please click, do you want to continue? And then there is a post-test evaluation form. You need to submit that form for you to get the certificate. Thank you.
How we will get the form for post-test?
Pardon me?
How we will get the form for post-test?
You get the marks for the post-test.
How we will get the form?
No, that will come as a pop-up. That's what I'm telling you. So once you try to log out, there will be a pop-up which shows, do you want to continue? You click yes, and then the post-test comes up on the screen.
Okay.
Thank you.
Thank you.
So this brings to the end of this day training, and so we'll just log out then. Thank you. Thank you very much.
Ma'am, can we close?